So today we'll be talking about stereotactic neurosurgery. Uh, so first we'll be touching upon the history because today's day and age, every brain surgery, more or less, like in except a trauma surgery or the emergencies, generally every brain tumor surgery or brain surgery as such requires something called as a neuronavigation. So today we have come to a status where we generally do a very high precision neurosurgery. It's so tailored that we just take out a very small hair from the patient's head. We take out a very small part of the bone. We do a small incision. We take small part of the bone. We enter. We do a small corticectomy. We enter and we just take out the tumor and do not touch anything else in the brain. We try to preserve the functional status of the patient as much as possible. So the idea is to give whatever the life that is left, that is going to be left with the patient. It should be a meaningful life. The patient should not be bedridden. So from where we started and where we have come is a big way. So we need to know where we have started. So stereotaxy, the history goes back to 1918, where Dr. Horsley and Clark, they developed the first device which applied a Cartesian coordinate system to a frame. Cartesian coordinate system, you might be remembering that XYZ system that we used to use in our class 10th, 12th examination during mathematics. So that particular system was used in a frame, and the localization of the patient's head, the calvarium per se, or the lesion inside the brain. They attempted to do it since the time of 1918, but it was unfortunately never used clinically. However, in 1947, Dr. Spiegel and Wycis, they designed the first clinical stereotactic frame, and they have used X-rays. So from X-rays, we have come down to MRIs now. Very developed 3 Tesla MRI we use in navigation now. They have started with an X-rays. From 1947 to 1980s, there were different types of stereotactic frames that came into use, but however, most of them didn't continue to be used. From 1980 onwards, as there was the advent of CT scan, as advent of computers, as well as improvements in other radiographic systems like CT scans and MRI. So you see, with the advent, we started collaborating the computers with the CTs and the MRIs. So, and with the collaboration, we also have brought something called as a digitizers, which will localize. Digitizers means something which is called as a localizer. So digitizers will tell us where we are in 3D space, in the XYZ space, where we are, where our head is, and where is the lesion, and where is our pointer. So there come slowly with the came the advent of the frameless stereotaxy. And frameless stereotaxy was invented by Dr. Davis Roberts and associates. And you can see these are the frames initially that was being used, and from there to computers and the slow advent of the frameless stereotaxy. So what is the utility? As I already told, it is mostly utilized during tumor removal, tissue biopsy, obviously in very eloquent regions like in a deep area of the brain, like in the brain stem, in the basal ganglia, in the motor cortex. We generally do not go and just take out the tumor. We have to preserve the function, because even in a millimetric or submillimetric distance, there are very important structures. So we take a biopsy and then we confirm the diagnosis and then go for surgery if it is salvageable. If there is not salvageable, we directly go for radiation or chemotherapy. Then deep brain stimulation, most widely used for Parkinson's disease, and the usage has been extended to essential tremors, obsessive compulsive disorder, and off-label has been used for neuropathic pain. All these things, they also use the principles of stereotactic surgery. And psychiatric disorders like Tourette syndrome and depression are also nowadays treated by DBS, which also use stereotaxy. So stereo means 3 dimension, and tactic means to touch. So we are touching something in 3 dimension, and there is another word which is called as a fiducial that will come across in this particular topic again and again. So fiducial is a point in the space which will tell us where we are. So stereotaxy, the definition is it is a minimally invasive form of surgical intervention that makes use of 3D coordinate system to localize small targets inside the body and perform desired action like being surgery, being biopsy, or whatever, being lesioning. So neuronavigation, which is the newest form of stereotaxy, it uses this principle and assesses target lesions in the brain. So we have got from a beginning to presently, we have got a frame-based one that we have seen initially to a frameless one nowadays. So frame-based one, we need to know a little bit about because they are widely not in use right now, except frame-based are used in DBS. This arc radius system is the most commonly used in DBS and stereotactic biopsy, and majorly was used now is frameless stereotaxy. So something about the arc radius system, the burr-hole mounted system, and the phantom target system we'll just touch upon. So what is arc radius system? So the arc radius system, it works with the center of arc principle, wherein there is a probe. I will show you the photo. This is the arc. You can see this is the patient head. This is the patient head which is draped. This is the frame, wherein the frame is fixed to the patient's skull, and in the frame there is an arc. So this arc has a probe, and the probe, there is a radius of the arc. The center of the arc is where the target of the lesion is present. So the probe will be the radius of the arc, and it will go to the center of the arc where the lesion is there, and it will cause desired action on the lesion. So that is the arc based system. Then we come to the burr-hole mounted system. The burr-hole mounted system is something which is not being used right now. Previously it was used, and it is a fixed entry point through the burr-hole, and it only through a hole in the skull you can only get a certain amount of angular degree of freedom and depth adjustment. So that was used a long time back. And now another very primitive system was a phantom target system. That was something called where there is a dummy head. So previously there was a dummy head wherein it almost mimics a brain. It is not tailored to every patient's brain. It is just an universal dummy head. And there are certain points like the globus pallidus or the subthalamic nucleus, wherever these are is just mimics a normal brain. So then there is a aiming bow at which is attached to the dummy head. Now this aiming bow will go and it will go to a certain, we'll just fix a certain point in the dummy head, and once that point we have fixed the aiming bow at, we take the aiming bow with the frame and attach to the patient's skull. We attach to the patient's skull. Now we just mimic the particular trajectory. So, but all this system except the arc radius system are kind of inaccurate. So slowly we have evolved from them. The arc radius system is by and large very accurate and is still in use.